Okay, so if you could all grab a seat and get the coffee and have a seat, we'll go ahead and get started. I don't really need a cheat sheet here to introduce Dr. Jordan because he and I go way back through Emory. I was at Emory before coming down here about 11 years ago. Prior to that, I was at Emory for about 20 years. And during that time, a medical student was on the service, and when I was a general surgery resident called Will Jordan. And then he happened to come back when I was on the faculty at Emory, and he became a vascular fellow with us at that point. I told the story last night that his father was a very successful vascular surgeon in private practice, and the family expectation was that Dr. Jordan was going to join his father, but he didn't. He decided he wanted to be an academic surgeon, and he went over to UAB where he joined the faculty, and then he became the chief of the division out at UAB, and that's a pretty busy vascular program. And you know, how long ago? A year ago, came back, 2 years ago, came back to Emory and actually became the chief of the division of vascular surgery. So he's had multiple roles nationally in the vascular world. Runs a very successful training program. And what he's going to talk about today really is about the omnipresence of vascular disease. One of the words we tend to use is you're only as old as your blood vessels. As we try to kind of raise money around the city, we are always saying, you know, what most of us are going to die from is this omnipresence of vascular disease. And Will's going to tell us a little bit about the importance of that in this lecture today. So, Will, thanks very much for coming down.
Everyone coming in and listening, because you know, at times doing this presentation it sounds a little bit dry because what do we really want to do is sort of looking for vascular disease. But I want to stress to you I believe the importance of a couple of items is looking for the disease, number one, and then number two, maintaining regular surveillance of patients after you see them. And I'm going to touch a lot on some aortic conditions, but I also going to go through some lower extremity disease and a little bit of carotid disease, because ultimately I believe the omnipresence is important. These are my disclosures. By CME standards I have none, but I do want you to know that I do clinical trials and also consulting work that's paid directly to my university. I want you to stop and think first about treating vascular disease and what really are the ultimate objectives, and that's to coordinate care so we can extend a patient's life. We want to extend it to have it a reasonably healthy life. I know these seem obvious, but I just want to at least lay these out initially. And I think the way to do that is provide good medical or surgical care. I really want to equate those two. We like to say surgery at surgery grand rounds, but ultimately I think it's simply providing good care, because also the outcome for our vascular disease is we die. I mean, we all ultimately die, so we're just really trying to extend it, and we're trying to figure out a way that we can extend someone's life so they can live a little bit longer and enjoy a healthier life. Now, some of this surveillance concept in the vascular world is born in surveillance of lower extremity bypass grafts. And you can see that, you know, particularly when an ultrasound machine became available to us in the 70s, that this is when suddenly this excitement about imaging and keeping up with bypass grafts became very important, because you can improve durability. Dennis Bandick was one of the first publications in the 80s. Bill Turnipseed also published in the 80s about the need for post-operative surveillance to detect some of these correctable lesions. And then there's certain value in that if you can use the laboratory to help identify it. So a little bit of a dry topic, but you can pick up a stenosis, and the whole concept is you can potentially intervene in a prophylactic fashion before a patient has symptoms, and you can improve the survival of the graft. And ultimately we think that helps our patients too. There's a single randomized prospective study that I could identify, and this is actually done in Malmo, Sweden, that looked at routine versus intensive surveillance of lower extremity vein grafts after they were done. And intensive being done at a Q3-month interval, which is sort of what a lot of folks are doing, particularly in the first year after a lower extremity bypass. And the routine just done once a year, and do it with simply a physical exam and a pulse examination, and maybe doing a cuff pressure. And what this Kaplan-Meier plot shows is that there are two different survival curves, and you got better survival, 82% survival at this 3-year mark, if you had more frequent surveillance, 82 versus 56%. They concluded that it's worthwhile. And that also, you can see, is borne out in some of these guidelines that are identified or that have been published. And this is a pretty old document. You can appreciate the authors there, DeWeese, Leather, and Porter. And the distinct advantage on this surveillance concept. These were published over almost 25 years ago, and you can see they're basically summarized in this single these few quotes here, that a pulse palpation alone is not reproducible nor a reliable indicator after arterial repairs. Well, that's a little bit dangerous. That says physical exam doesn't make a difference. And this is the reason where they looked at some specific parameters, including the ankle brachial index, and see if there's a change from post-operative and immediately post-operatively to later. And then also using duplex imaging to see if you can identify a problem and treat it prophylactically. Incidentally, some of these other concepts of surveillance is also this concept that there can be other sites of vascular disease, such as an abdominal aortic aneurysm that occurs in almost 10% of the patients. Here's a study that was published in JVS in 2008 that really looked at the concept of surveillance and prophylactic reintervention was important to maintain durable results. And you can see that this difference between both claudication and critical limb ischemia identified that critical limb ischemia had worse outcomes, and you had to be pretty intense. And here's one of my own patients that I was treating for CLI. You can see that in the follow-up of this vein graft had a velocity up almost 5 meters per second. You'll also notice the multiple stents that had failed in this lower extremity case. But had a very focal stenosis right there in the mid portion of the graft, not a typical spot to be seen, sometimes associated with valves. So we simply treat this with a balloon and have a very nice result. And we are high-fiving because we think this is a great way to solve this problem. And we suddenly don't have this problem of having acute occlusion we got to deal with in the middle of the night or drip some lytics overnight and take care of this. Because clearly once thrombosis is initiated, these graft survivals are not near as good. Well, actually when this concept, and I present this to you because this is some unpublished data, just some comments that I'm going to show to you next, because I think we've all promoted this concept of surveillance for lower extremity grafts. And about 3 years ago, the SVS charged a certain writing group of the membership, and then that turned into a commissioning to this evidence-based practice center at Mayo Clinic to figure out if this concept of regular surveillance of lower extremity grafts truly was going to help us. Is it truly beneficial? And this research group at Mayo basically looked over 369 publications, only found about 115 that were relevant, but only 16 had eligible information to do a true meta-analysis and had adequate information. In their conclusions after doing this, and again, this is unpublished data, so it probably should be out within a year or so, that they actually concluded that duplex surveillance was not associated with improved patency, improved amputation rate, or improved survival. Now, they didn't have an odds ratio yet for the patency rate, and it's probably because of heterogeneity of the data that came through. But the real point is this was a surprise, because this suddenly meant to us no more graft surveillance. Well, if you talk about this concept of evidence-based medicine, and this is this Mayo group that was this commission paid for by the Society for Vascular Surgery, we need to look into this concept of surveillance. Is it really worthwhile? Now, this is almost heresy for us to stand up and say, you know, you don't have to keep following grafts. I know the evidence doesn't show it, but if you go try to take your board exam in vascular surgery and say, just do a bypass and just tell them to come back when it hurts again, you're not going to pass. You're going to be coming back the next year because that is just so ingrained in what we're doing every day. And this is a concept, and when you really start looking deeply into evidence, it's not really there. And so that's where the suggestion is we might have to look at this a little bit differently on whether or not surveillance makes a difference. So I also then want to think about the concept of surveillance doesn't really make a difference. What about this screening concept? So I'm going to digress for a moment, but I'll flip back to this momentarily. Should we apply these principles of what we know about vascular disease to screening patients? Now, I think screening is distinctly different from surveillance. Screening applies when you're looking specifically at a set population and try to figure out if they have that disease. Not unlike this little mill where they're simply screening for aneurysms. You know, we like to do that because we want to pick up those nice small aneurysms that you can treat very easily and get in and out. But surveillance really applies to monitoring a vascular population for a recurrence of disease or progression of disease. Once you're identified with an aneurysm, how quickly does it grow? Once you're identified with carotid stenosis, what truly is at risk, and how can you help manipulate that potentially with either medical therapy or intervention? So when we talk a little bit about screening, let me tell you a process I went through when I was at UAB, and again I spent a few years there after I had my influence from Dr. Lumsden, and I'll touch on that shortly in a minute. We actually wanted to start figure out if we could find a screening population, and one way we did this is first look at those patients who came to primary amputation. who are the patients, when we think about lower extremity disease, who come right to amputation. You don't ever get a shot to try to open up an occluded SFA or try to do a bypass to a tibial. And we found that of these 80 patients over a relatively short period, it's a year and a half, what were the risk factors that really went right to primary amputation? And you can see there are a series of odds ratios here, but ultimately this difference is there were 3 factors that were identified, and that is those patients who were greater than 70, the non-white population, so that included Hispanics and African Americans, and diabetes. And it's interesting that we identify these, and the highest risk factor is being non-white, but diabetes was still a 1.9 odds ratio with a pretty substantial confidence interval. So when we think about that, the most important one was age. And so we said, let's see if we can figure out a screening protocol that we might be able to identify those patients. And we thought, let's go after age. That seemed to be the highest on that initial list. But age is a little bit of a challenge, because if you start to think about the silver tsunami, and if you think, what is a silver tsunami, it's probably not real good to talk about natural disasters around here right now. But the silver tsunami is this concept that the baby boomers are now 65, and it was in 2011 when suddenly they started to hit 65. So remember, after World War II, everyone got back to building families, and so that's when the boomers were born, from 46 to about 64, and now this group is getting older. This group is actually going to be over age 65, and when these 40 million boomers turn 65 starting in 2011, we're going to see continued growth, and 20% of our population will be over 65 in 2030. Why is this important? Because this is where there's a huge prevalence of peripheral vascular disease. We couldn't exactly figure out how to screen 8 million people, or even in the city of Birmingham 1 million, if we're going to be able to identify all those. So we started to look for something that was more practical for us. So I showed you those 3 risk factors: age, race, and then diabetes. And based upon operational challenges at our institution, it turned out that the diabetic clinic was the easiest way to screen. So we started to go down this screening pathway. We screened almost 400 patients over about a 2-year period. And interestingly, we only found that 30% of them had any indication of peripheral arterial disease, and that could include, basically had to have some plaque or abnormal finding objectively, either from a duplex examination or an ABI that was abnormal. And you can see the risk factors that were listed here, and those being male, but it's actually coronary disease. Coronary artery disease had the highest odds ratio of almost 2.5. And these are all diabetics, and you can see even insulin use was not quite as high as you might think. And actually, heart disease was a higher risk factor than smoking itself. So suddenly we realized that this screening probably was not going to be the best way to really have a huge impact when we looked at these 2 pilot studies, so to speak. But I still want to sit back and wonder then, is surveillance, so once that diagnosis is established, can we do surveillance and can we improve long-term survival? Now, this is a little bit different from some of the other surgical concepts we deal with, particularly on aneurysms. We think, hey, you fix an aneurysm, go away, come back when you need me. That's sort of the surgeon's mantra at times. And I think in the vascular world, we got to think a little bit differently, because this disease progresses in a lot of other locations. So while that standard might apply to doing a cholecystectomy, doing a hernia repair, it's very different. It's almost like cancer surveillance. I think that's an important component, because I still believe that vascular surgery is palliative care. When we reconstruct them, we've not solved the disease, we've simply taken care of the initial problem. Now, we also recognize that when we did a lot of this open AAA repair, it was a durable operation. Probably was durable enough we didn't have to see them back. It is a major procedure, and a lot of them sometimes didn't want to come back after they finally recovered. But then I want to stop and tell you, let's think about EVAR for a minute. When endovascular repair came along, there were some challenges to this concept of surveillance, because the surveillance intensity went up dramatically once EVAR came along. And there was some concern about the durability. Why? Because the fixation is very different. You're not sewing it in place. You're putting an old endograft in place. It's shown in this poor gentleman's autopsy specimen. Because this frequent imaging was really done, this frequent surveillance was done after EVAR, because we were unsure about what the long-term outcome would be, and that's why the surveillance increased. And it also identified that there was a reasonably high reintervention rate after endovascular repair. And the real question then we ask, does this reintervention rate really mean it's treatment failure? I'm going to suggest to you that we're really re-intervening, and we probably ought to be re-intervening in other areas too, and if we start looking, we can find it. Let's talk about EVAR when it first came along, and this is some other Eurostar publications. Came out in 2000. Remember, Europe was about 5 years ahead of us in terms of getting these cases, getting that technology. We actually sometimes can even view them as being our experimental ground, so we can see how it starts out there and then we use it here. But when they looked at their first 3 years of experience, 96 to 99, had 1,000 patients in this Eurostar publication, almost 1 in 5 patients required a secondary intervention. A lot of those are transabdominal. They had to go explant them. 76% were transfemoral, so they had to do some type of intervention. But when they translated what they learned in that Eurostar in the first 3 years, and they started doing these randomized studies, the DREAM study, the EVAR-1 study, the ACE study, they all identified that there's a little bit, the durability is not quite the same, and there was a higher reintervention rate. And that's why the endovascular naysayers hopped on that bandwagon and said, you know, this is perhaps not so good, but I want you to stop and rethink this. While the reintervention rate is higher, that did not equate to a higher mortality. And while we're thinking, if we're going to use the endpoint of reintervention, I want you to stop and think about survival, because that's ultimately what the patient really wants out of this. They don't care if they have an endo leak. They just want to know that they're going to survive a certain amount of time. They want to see their grandchild graduate from school or get married or reproduce. So there are a variety of things, that these objectives that some of these elderly patients want. So we looked at some of our own series, and this is going to go back to my UAB data, because this is have longer term follow-up there. We looked at roughly 10 years of our experience with EVAR, and we started in '99. That was actually when it was commercially available. And we were doing a moderate volume, but you can see this Kaplan-Meier plot really sort of shows, you know, the reintervention rate, and the multiple lines just sort of say how we did it. If you look at the bottom line, these are all reinterventions, and these are the variety of reinterventions. That unlabeled spot right here is embolization. Our reintervention rate was not near as high as it was in Eurostar at 1 year. Eurostar was 8% in 1 year. And we look at the DREAM trial, that's that Dutch randomized trial that was published in New England Journal. They had a 12% reintervention rate at 2 years. So again, we're not a randomized trial, but we were pretty intense on the surveillance, probably not quite as tight as an RCT. But again, our reintervention rate just was not that high. And when we started looking then at what we could do afterwards, and I'm going to take you through what some of these reinterventions were, really to point out that this, I believe, was related as much to the surveillance protocol as anything. Now, we did think it was higher than after open repair. It was about 10% at 5 years for us. Again, not as high as the others. And that sort of added to this concept of this question of EVAR durability. And also made me stop and think, what about reintervention after open repair? We just hadn't been tracking that as much. I think potentially the best study to identify that is the VA study, the EVAR trial, that was published, first author Letterly, was published in 2009 in JAMA. And this is where they randomized over 800 patients, open versus endovascular repair, and they looked at these other outcomes, including secondary therapeutic procedures and what have you. And this is their the table 3 from that publication, again, JAMA 2009. And you see it's sort of hard to read from the back of the room, but first the all-cause mortality was statistically equivalent, but it was about 7% for endovascular repair, and it was almost 10% for open repair. So there was a subtle difference, but statistically insignificant. But if you look at the secondary procedures, they actually were very similar between the two, because they tracked some different items. The EVAR column, they tracked endovascular reinterventions. There were 3 explants, some open arterial reconstructions, and some groin wound complications. Percutaneous was rarely done in this group, if at all. Then you look at the open group, and they had a 12.6% rate of reintervention, or they call them complications in this series. 24 of them related to incisional hernias. Is that because the bozos didn't know how to close right? No, I don't think so. I think that's related to the connective tissue problem that probably coexists between the aneurysm and that fascial healing. But you can still see the other problems. They also include 6 additional laparotomies, because there's a certain number of small bowel obstructions that occur after those patients get adhesions. And they looked at this and they were equivalent. So I'm going to look back at our own series that showed some UAB data. This is 1,000 patients who had EVAR. What were the reintervention rates? We started to look at non-AAA reintervention rates. Certain number of thoracic repairs, and only 9 patients here. 54 patients had lower extremity repair. Some of those potentially were related to access, but clearly not all. 14 patients had carotid repairs. Those total of 7.7% total that went into non-AAA related, some were thoracic. Look at the open repair group. It's 6.7% here, so it's very similar to the two. Thoracic, lower extremity bypass, and carotid repair all had some intervention. Here's a patient that actually didn't get the first intervention here, but I like to point it out because this is someone who had an open repair 2 years earlier, then came back with a ruptured aneurysm at the distal anastomosis. So again, is this because the surgeon didn't do it right 2 years later? No, I think that you can have these kind of complications that occur after open repair. This is one that I think if it had been in a surveillance protocol, probably would have been identified before he ruptured, before we had to do an endograft. Let's look at some of the non-vascular interventions after this series. So this is after open AAA repair, 800 in the group. There was a 13% of patients required some type of surgical attention. So I actually counted some of these partial small bowel obstructions if they required hospitalization. And it was a reasonable number. There were some incisional hernias. Again, I guess the resident didn't close that right. And there was some other GI pathology that you always wonder a little bit how much this might be related to the intervention, particularly when it might be ischemia in the left colon because the IMA is so frequently sacrificed. When I tried to tabulate those, when we tabulated those two components, we could see the reintervention rates were really very similar between the two groups. The EVAR group versus the open group, it's about 20% over. This is almost 10 years of tracking patients. And also it extrapolates into this survival curve that shows on the blue line the endovascular patients actually had better survival over the long term, which was distinctly different than some of those other studies. When you look at the DREAM study, you can see at 2 years, it's almost at 1 year, that the survival curves really match between the two, endovascular and open arm. When you look at the EVAR-1 study, their survival curves, one of these is a survival of aneurysm-related mortality, the top one, and the other one is all-cause mortality. They basically were superimposed on top of each other. I actually wonder if it might be different in the real world, at least in our own experience. We started to do some other studies and look specifically, we initiated this study to look at sac expansion after endovascular aneurysm repair, what everyone's been doing. It was presented and published from the Society for Clinical Vascular Surgery a few years ago. We had 800 aneurysm patients who we could follow over a long enough time that we could assess for sac expansion. We wanted at least a 1-year follow-up. And you can see that of those, almost 300 had an endo leak on at least one occasion. 219 of those were a type 2 endo leak. And then we wanted to see of the type 2s, how many actually grew. So you can see 27 of the 219, so a little bit more than 10% had sac expansion. And 21 of those patients underwent secondary interventions. It's a little bit challenging on the type 2 endo leak. And the reason I bring this concept up about the type 2, how much did this really impact their outcome, and are we really helping them by embolizing? So what we found, not surprisingly, just to show you quickly, is the aneurysm sac growth at 10 years, so we're following patients for 10 years. If you didn't have an endo leak, that's the top line, that your aneurysm was very unlikely to grow at all, and if you had a variety of components of endo leaks, it would tend to grow. Type 2 a little bit, didn't start happening until about 5 years. Type 1 and 3 would happen sooner, so obviously those are the ones we would chase. It wasn't really earth-shattering news, but what was more impressive to me is when we look at this survival plot, that we basically found that those patients who had a type 2 endo leak, they had the best survival. So is a type 2 endo leak good? Should we look for a type 2 because that makes the patients live longer? I suggest to you it sounds a little bit odd on the logic. Alan would tell me that that just shows the validity of the data because something's really messed up in it. I actually think this has to do with the frequency of visits. That these patients who come back, and so this is the next thing we do, and the point is that these people are attentive to their own care, and that's one of the reasons they want to come back. We actually go looking, we can find the endo leak. We don't always intervene, but it's just once you're identified with it, you might be better off. And the suggestion is we potentially should survey these patients more frequently. The challenge is not to over-treat, and I'll touch on that in a minute. Let me stop back and tell you about the surveillance recommendations that were published, sanctioned by the SVS. Elliot Chaikov's the first author, and it said, how do you keep up with patients after an aneurysm? Basically, it says after you do an open AAA, you ought to at least do a CAT scan, essentially a total aortic CAT scan at 5-year intervals. Now, after EVAR, we've been doing them annually, and this is as much based upon the clinical studies that occurred, and also the concern about durability, because there may be failure that occurs sometime down the line. And that's one of the reasons we've done it. I can tell you most practices, including my own, we've shifted really almost to ultrasound surveillance and only do the CT on the ones that are difficult to image with ultrasound, a la the obese patients. I know you don't have that in Texas, but we still have it where I'm from. And you also, and those are ones you might do CTs, but I really try to get to ultrasound surveillance because we can get pretty good imaging. So ultimately I wonder if this surveillance can improve the survival and also reduce some emergency procedures. Here's a patient. Study carefully, Dr. Lumsden. 50-year-old when he was first treated. 1999, he had some treatment, including his legs, his cerebral aneurysm, and an open AAA done with Dr. Lumsden and Dr. Bush. I actually found the operative note. And then also had to have some leg work, including a thrombectomy of one graft. I think Dr. Salam got to do the thrombectomy. And then after I got back and finally got information from my professor going back to 1994 that he taught the pupil, I got to do his next operation that was a suprarenal AAA that you can imagine came in on the weekend. Everyone's all excited it's going to rupture because you can still sort of appreciate it. Let me see if I can get that to stop at the right spot. No, right back there. And you can appreciate this, almost this nodularity to this aneurysm that goes right there, and it was easily pulsatile in this obese gentleman, and it went up the suprarenal segment. And you know, I was a little bit disgruntled because suddenly it's an emergency, and why do I have to go deal with it in the middle of the night? And this is one of these ones that I actually believe if no one had picked this up, he certainly would have ruptured because of this elliptical shape. It actually measures right 11 centimeters if you measure it in the AP position. But it's one that clearly has that morphology that could bust at any moment. This is one that had missed surveillance, but you know, we caught it anyway. Let me talk about I'm going to show you some other surveillance anecdotes, and this might help sway you some. It's a 68-year-old gentleman, initially had a AAA repair in 2003. It was an open aneurysm repair, and then we evaluated him last in 2006, came back 4 years later and had a surveillance CT scan. Graft looks pretty good. We do a total aortic CT, looks just fine, but you know, we go and do the chest too. It's sort of hard to get good ultrasound there. And lo and behold, what do we identify? He had an incidental pulmonary embolus. Wow, he had a little bit of shortness of breath, but a lot of my smoking patients have a little shortness of breath. So you wonder about that. This patient, we did an ultrasound of his legs, couldn't find any DVT. Do we treat him? Do we not treat him? You know what? I gave him a typical course of warfarin, and he really did okay. And I'm suspicious that these are one of these advantages that you identify that you might improve survival. I realize this is not hard, randomized prospective data, but it's still data to look at. Now the real key, what's going to keep me from going and driving a catheter in there and doing lytic therapy is we got these PERT teams that come along and want to go chase a pulmonary embolus. I think that's where it takes some judgment to be a little bit careful. Here's a lady that I treated in 2002. I showed a brief image of this yesterday that I'd seen just for a couple of times, and she missed her surveillance, and she reappeared 6 years post. If you can appreciate, that's the endograft here, and the endograft had completely fallen into the aneurysm. She had a tender aneurysm. I had to admit her and take care of this on an acute setting. And it was a little bit unfortunate. And really just I show you this because we almost video all of our open cases now that Alan's taught me that it's probably important for documentation, but also because you don't get to see that much. And this is what we would say is tight as a tick on a hound, I guess, the way you see it pulsating. And I bring this up because this was a missed surveillance opportunity. And now we're dealing with her, and she actually was on Plavix, but based on the tender aneurysm and the diameter, I elected to go ahead and take her to the operating room and operate through the Plavix. And I just show you some of the concern when people don't appear, because this created sort of an urgent situation we got to operate on. And some people also like to appreciate what this looks like on some of these failed endografts. I'll let it run for just a moment more. Could probably edit it. And you can see as we pull it out, the interesting part for me is see that the resonator on the screen left was most interested in the bleeding at the proximal anastomosis, and he was sticking his finger there, and I'm more interested in the graft that's down here at the bottom because I'm trying to figure out why this thing failed. The bottom line is we got the lady through the operation. She was old and fragile, didn't get out of the hospital, and I think that this was a missed opportunity of surveillance, and that led to her ultimate mortality. Incidentally, when I had to go talk to the family about her mortality, they were eternally grateful that she'd gotten 6 more years. I felt bad because I'd lost her. They were like, hey, thanks for giving her 6 years, so some of it's perspective. So let me talk about how some of the aortic disease then also can translate into other areas. I mentioned carotid disease, I mentioned lower extremity disease. Let's talk about some carotid disease, particularly on this Marfan's patient. Obviously, those are potentially in a different category, but I wonder if there's some heterogeneity between this Marfan syndrome and what we might see in some of our other young patients who have disease. This patient first had a proximal thoracic repair in 2004, then had a thoracoabdominal repair in 2006. That one was done in St. Louis. I had some postoperative complications, including a stroke and a right hemiparesis, not spinal cord problem, but a left cerebrovascular event. He got to me in 2011. Really he was complaining of hoarseness, and you'll appreciate that he's got this anastomotic aneurysm that's sort of hanging out. It's right where a recurrent nerve would be. He was not hoarse after the last operation, or he was afraid to complain about it because he got a stroke and he didn't want to have to deal with that other problem too. Regardless, he had this, and I got asked to see him about doing an endograft. The cardiac surgeon sent him over, and I did an angiogram. I just thought it was important because I was really planning to do a carotid subclavian ahead of time. This is before all the guidelines were out. And lo and behold, I looked at the carotid and identified this carotid aneurysm, and that's a pretty substantial aneurysm. Potentially could have been there when he had his stroke the first time, and I don't know all those details. It was done at a different institution. But you wonder if that might have been a contributing factor. There wasn't much thrombus in there. There's a very highly selective view. You can see I have the catheter right in the ICA, and you can appreciate it. Again, not much thrombus. Could that have been the cause of his stroke? Could that also be the cause of his hoarseness, pushing on his nerve that high? So we did a carotid subclavian bypass and a carotid aneurysm repair, a bypass, and then we did the EVAR case and had a pretty nice result, and he recovered reasonably well. And I really submit this one as another example of, say, when you just look a little bit harder, sometimes you can find something. Did I need to treat the carotid aneurysm first? You know what? There's not hard evidence-based medicine that says I should, but I clearly think that helped this gentleman recover nicely, and you can see the carotid repair done there. This was all done during a single hospitalization. Ultimately then, let's talk about carotid repair too. Is post-operative surveillance really that important? Well, routinely we like to evaluate the endarterectomy site. Again, it's really drilled into us that it's important to check your work after you do it. Some people do it at 1 month, some people at 6 months. The recurrence rate is relatively low for recurrent carotid stenosis, and the reintervention rate's probably half or even less than that than what the actual recurrence rate is. So is there surveillance really needed? Sometimes it's related to the contralateral side. Let's talk about what the standard is. The standard might be listed here, and this goes back to some data from Pittsburgh, published in 2004 in JVS, that said this, it's important because of 472 carotid endarterectomy sites evaluated over 10 years, there was progression of 8.3% stenosis per year, and some of those would progress to occlusion. Dennis Bandick out of South Florida also published a similar finding suggesting that surveillance is important. This is a Pittsburgh data showing the KM plot that suggests that 20% contralateral disease progress to the severe category and thus warrant reintervention. So is it really beneficial? Kim Hodgson out of SIU published this series that said there was a definite recurrence rate, and when you get out to 10 years, almost 1 in 4 patients have a significant recurrence. The contralateral argument, one came out of Dave Cole and Dave Cole's group in Greenville and Spence Taylor's group, that they basically said, maybe we're just doing carotid duplex to pad our pockets because we can get our vascular lab doing more studies and we can gain more financial benefit. So it's a little bit of back and forth about whether or not we should do it. Again, I'm going to look at some long-term data from UAB, because that's where we have it, followed really for 10 years. And it's just a quick KM plot to show of these patients, and you can appreciate that there were over 1,000 patients, almost 1,200 patients in this series. And we basically categorized in those who came back on a frequent basis to come get their follow-up. And our general protocol was you do it usually at 6 months and then once a year, and we would occasionally space them to 2 years when things look reasonably stable. Interestingly, those who kept those regular appointments, despite our encouragement for them to be there on a regular basis, you can see 413 did not, but the survival curve is in blue. Survival curve for those who kept a regular appointment was substantially better. All right, someone's going to argue, well, the ones who didn't come back because they were dead, that's why they didn't come back well, but I'm suggesting we identified the mortality after they missed their appointment. Let me take you through a couple of cases that sort of demonstrate that. Here's a patient that I actually, again, felt concerned because he failed surveillance. We had it in the surveillance protocol. I actually first treated him in 2005. I did a carotid on him. He also was identified with a 5.2 centimeter aneurysm. Put him in the high-risk category. This is right here at the left renal artery, so he really wasn't a very good endovascular candidate. Again, this is 2005. He didn't have a very good heart. You know, you're probably better just sitting tight. Let's watch this. Well, he didn't want to keep coming back, so he just showed up when I got that call on a Saturday night when he'd ruptured at the outside emergency room. His creatinine's up to 4. He's in pain, he's hypotensive. So we get him around and get him to us, and we do an endograft and get sort of fancy. Still didn't quite have the heart to go jump in there and fix him open, because I thought he had a better shot, particularly because I was willing to sacrifice the kidneys because his creatinine was elevated and I thought he didn't have much. He had a type 1 endo leak, had to go take him back and do a snorkel type graft up into the SMA. Incidentally, I'd put a right renal stent when I did his angio back in 2005, so that helps mark it, and that's what you're seeing there. And the irony was, we finally got this treated. We did a type 1 endo leak. This is an off-label indication. There we are in the SMA, and we got him what I at least thought was sealed. We had a very small endo leak, but he stabilized. Follow-up CT scan, this will kill you. See that? That's the right kidney still flowing, even though I covered it up. So when you don't want to cover them, you lose them. When you try to cover them, they still flow. But he stopped bleeding. We thought we were great. He did require dialysis as expected and did fine until 3 weeks post-op. He just up and died, as they'll say. And it was probably a dysrhythmia. We got an autopsy on him, pushed pretty hard, and we identified that, it really looked okay. We had sealed the aneurysm. The point is, if I had gotten to this in an elective circumstance, I clearly believe he would have been better off when we could have addressed this if he'd been followed rather than creating that 5-year interval between the two. So this is the carotid patient. I wish he had come back, and that's where it's hard. You got to emphasize them to keep coming back. Let me show another case of a failed surveillance on a patient after a carotid stent, and this just shows the restenosis rate after carotid stenting, some prior published data. Here's one that was about 5 years post. 6 years post. He was first treated at 42. He had bilateral carotid stents after a left hemispheric stroke, so left hemisphere went out. He had bilateral recurrent stenosis. We looked at him. He had to have some heart work. They said, can you optimize his carotid condition first? Said, that right side looks bad enough. That's his better hemisphere. So I said, okay, let's just go take it out. So we took it out, put a patch on it, really did just fine. Discharge 1, post-op day 1, sort of typical. Came back at 3 weeks, really was going to go after the left carotid. He'd occluded the left carotid, completely asymptomatic. That's an old infarct you're looking at in the left hemisphere. We said, you just treat this with Plavix. We've got one carotid open. He's remained asymptomatic. We don't have to reopen that one. I suspect the left one occluded because I had improved hemodynamic flow on the right side because I hadn't done anything to the left. He stopped coming back. He did get his heart fixed. He showed up 11 months later. He missed his 6-month appointment. He was readmitted with a hypertensive crisis. It worsened. He basically went into a comatose type state. They got an angiogram done in radiology, then called us after he'd occluded both sides. Well, he was comatose because he had no blood flow to his brain. Anyway, we looked at him. He was in pretty dire circumstance. I thought it was reasonable to take a shot, so we took him to see if we could thrombectomize the right side. We got it out. We got the debris out. Had to put a graft. There was a lot of disease in there. I need to learn to clean up before I take those pictures. We took him back to the ICU and did this barbiturate coma trick. No real recovery, ultimately expired post-operative day 14. I believe if I'd had him at that 6-month interval, I would have had a better shot at helping him survive. So I bring this same survival plot back to say here's some opportunity, and I think that with better surveillance, that I think that we can carefully select some appropriate patients and have that intervention. So I bring back the same KM plot that shows that EVAR is probably better than open repair for long-term survival, but it might be something as simple as the surveillance. So the real question is, how hard should we pursue surveillance? I believe they do have multisite disease. I've tried to show you the cases and some indirect evidence on why it might help. I think evaluation and imaging commonly reveals vascular and other non-vascular disease, the pulmonary embolus, or even sometimes some cancers. I didn't even touch on that topic. In these regular evaluations, at least at our data, shows that it correlates with a longer life. Is it really worthwhile, though? The real question, when you find an abnormality, how aggressive to be? The patient thinks that, yes, prophylactic therapy is good. The payee, insurance company, they're less likely to approve it. I hate to think it's a money game, but you still have to wonder how much that's behind the entire picture. A single conclusion slide, and that'll leave us some time for questions. I do believe vascular disease is becoming more prevalent. I mentioned the silver tsunami. The regular evaluations can discover multisite disease. I do think we still should have caution when we do that because we don't want to overtreat. And regular surveillance improves survival, at least on the data that I've found in my own practice. Thank you all for your attention, and I certainly appreciate the honor to be here to present to you this morning. Right on time, right on time.
Right on time. Before we take questions, let me welcome, this is interview day for Cardiology Fellowship. We can always spot the well-dressed people basically who joined us that morning because you put us all to shame. So first of all, except Will, are you interviewing for Cardiology?
You never know. You never know.
So just welcome to Methodist. We really appreciate your interest in the program. As I say, I've worked at many academic institutions. I can tell you that the quality of the cardiology faculty and the private physicians that you get to work with here are frankly second to none. I don't think there's any weakness in any of the different subspecialty areas. And what I always say to people, it's as bad as it's ever going to be right now. Just imagine what it's going to be like 2 to 3 years from now. It's just going to be phenomenal. So welcome and thank you for your interest. So questions. Dr. Zogby.
Enjoyed your presentation. Thanks for coming.
Thank you.
Are they good? How much heterogeneity is there in the approach among the surgeons if they see something in the surveillance? I mean, obviously the extreme cases are easy, and are they still very individualized from an approach point of view, or are the societies coming up with some strong recommendation, and how strong is the data? I know you shared a lot of data with us.
Right, so that's a great question. Thank you for that. Actually, the document to establish more standardized surveillance protocols is in preparation. It's going through the review process, and I actually am on that writing committee that was involved with it. It was a huge task to try to put it together. And while the recommendations are there, the real final conclusion is the data is intensely sparse. We have a lot of work to do. Because while we have opinions and a lot of our recommendations are based on low quality evidence, and we acknowledge that. And even when I show you the group out of Mayo that looked at this surveillance concept, that we have pretty strict criteria. Look for velocities over 3 meters per second, look for ABI change of 0.15, that those are pretty hard criteria to chase. That there's probably less heterogeneity there among most practices. I think the evidence that says we have to do that is not that strong. Now, in terms of start looking at recurrent aortic disease, I think that's a much bigger problem to deal with, because I'll follow some aneurysms that are reaching 5.5, 6 centimeters when I think that the complexity of the repair is too great to push the 85-year-old to do. And so that's where I think that we still have a lot of work to do, but you should see an SVS sanctioned document, I'm hoping within 6 to 9 months. Thank you.
Let me make a comment before you jump in, Eric. So it scares me a little bit, this idea of surveillance everything. One of the reasons is that they used to say that a good surgeon knows how to operate, a really good surgeon knows when to operate, the best surgeons know when not to operate. And the problem is that you unmask huge amounts of disease. Who's going to basically say when you don't intervene in those patients?
So ultimately, despite this teacher-pupil relationship, I still disagree with them a lot, all right? Ultimately, the answer is whoever holds the money, because that's the golden rule, right? That's who's going to answer it. But I also think that when you uncover the disease, the caution in the judgment that you use on caring for it, and this is where we need guidelines, I think that goes a long way. And I showed you the PE case, and the guy potentially had symptoms, and an aggressive person, I could have dropped $25,000, $30,000 putting that guy through some other intervention. You know what? I gave him rat poison. That's pretty cheap, right?
Whole body CT scanning, top to bottom. You turn age 50, you get a Medicare, or age 60, you top to bottom. Let's figure out where it all is.
So that's screening, a little bit different from surveillance, and that's the other comment that I do think there's some distinction there in this screening. And I actually looked up in preparation for this talk. I looked up the lifeline screening concept, and I'm sure you've seen that. We get those flyers in the mail at my home now. The lifeline screening, screened millions of patients and identifies some disease, but there's still some doubt whether or not that's truly beneficial. And actually the SVS did not endorse that because they were not confident that the screening was done how it should be. I had a patient of my own who I'd treated an aneurysm with an EVAR. He had a calcified wall, so it never really shrank, and he was sort of hanging at 7 centimeters, perfectly stable, no endo leak. He was convincing his friend to go to get the lifeline screening. He went to the lifeline screening too, because he just wanted to see, and he had enough money to throw down $150 and get it. He said they screened his abdomen for the aneurysm. They saw a 7 centimeter aneurysm. They pushed him out the back door, and they were white with fright and said, "You better go right to the emergency room." So this just shows a little bit of, lack of a better term, ignorance about what you're finding, because he had clearly a stable situation. He got a chuckle out of it. I would have spent my $150 somewhere else.
Well, I guess I would question and maybe argue that the the surveillance that we offer isn't really to pick up surgery thing, it's to encourage better medical treatment of those people, right? When you hear a surgeon saying, I'm gonna cut your leg off if you don't stop smoking, what's your cholesterol doing? Go back and see your guy. It doesn't matter that your total is 190, it's that your LDL is 120, right? And that's gotta be treated better. Your blood pressure is wacky high today. For me, I think it's really encouraging the better medical management of these people is one of the things we really offer with surveillance, not so much picking up the new leg lesion or carotid disease or something else. I think that's a huge thing in my practice, and I presume it's probably the same in yours. And secondly, I guess I would ask, so what about the surveillance of these people who get endovascular leg procedures? I mean, the guy who gets an angioplasty of his tibials to heal a toe wound, are you going to see that guy in 3 months and find the stenosis and reintervene? Because that's a whole different kettle of fish than watching your long leg bypass.
So Eric, thank you for the question. I think that point's very legitimate. Incidentally, we had in my prior practice in Birmingham, had a vascular medicine person practicing with us. And we're working towards that avenue at Emory. And I think that goes a long way because they do sort of balance reintervention versus optimizing medical care. And I think a lot of surgeons walk into this and they don't want to sit there and have to tweak the LDL versus HDL and which medication to use because that takes extra time. So I totally agree that this concept doesn't mean you've got to push somebody to intervention, and that's where we advertise ourselves as vascular specialists, and that's a term I picked up from Alan, that we need to think about every avenue of treatment, whether it's medical treatment, endovascular treatment, or open treatment. So again, that's where I tried to bring that caution up a couple of times. And lastly, endovascular intervention for legs. That is a full subheading in this document we're preparing, and it's clear that I would sort of suggest in between the lines and what you'll read when you see the document is that it's probably worth following these patients, and the point is that you shouldn't just simply do the procedure and say you're done, go away, come back when it hurts, because a lot of them went and had that lesion shaved just because it was identified instead of truly being symptomatic. But we still have a absence of data to really add to that. One observation that you can see in some subtle publications is that an endovascular failure does not seem to be as severe as a surgical failure, basically when they clot. Well, that depends, and I think it depends upon what you're doing. If you know not to jail the profunda and knock the profunda out the whole time, that's probably true, but there needs to be some caution in how that's done. So getting to your next point, I think that even if you do an endovascular therapy, that patient should be surveyed. We just don't know exactly what that interval is ideal. And also to point out that the surveillance probably might even help to push them more to better lipid management and other antiplatelet therapy. I just think I've not yet found a circumstance that I would intervene for an asymptomatic leg. Intervene with endo or surgical therapy. I would do medical therapy. If someone had ABIs that were low and they really had a bad LDL, I might drive them more to statin therapy, but right now that data is not real strong. One of those quality metrics in VQI is to look for statin and aspirin after intervention, but it doesn't say anything about the patient who's identified as not yet had intervention. It's sort of a long-winded answer, but I think that is close to the category.
Yeah, I think the important take-home message is there is almost no indication for intervening on an asymptomatic lesion in the leg. In fact, I can't think of one. The other thing is to think about the aorta as an organ system. One of the things we used to see was a patient would get a CT scan of the abdomen and pelvis, because a lot of these scans are done under the umbrella of the Heart and Vascular Center. And so some of these issues that you're pushing on are highly relevant to us. And so you would see a CAT scan of the abdomen and pelvis, a patient would have an infrarenal line, it'd get repaired. And there would never be imaging of the thoracic aorta. Now that's, in the general surgery world, that's like finding a sigmoid colon cancer, taking out your sigmoid colon and not getting a colonoscopy because there are synchronous lesions. The highest incidence, highest risk factor for having a thoracic aneurysm is an abdominal aneurysm and vice versa. And so part of this is you're ordering these scans, call it surveillance, but it's good medicine, is to make sure at some point in time there's imaging from the aortic valve all the way down really to the groin, because they also have a higher incidence of femoral aortic aneurysm and popliteal aneurysms. I think we should call it a day there. One last comment from...
Where does MRI
Where does MRI fall? I mean, you mentioned ultrasound, obviously, and CT. Where does MRI fall into your surveillance, et cetera?
I'm a little cautious answering that question because I think there's a surgical bias towards using CT over MR, but my high-level boss at Emory is an MR specialist, so I have to be careful dissing MR too much. And you know why? I think it has to do with some of the anxiety factor of patients getting into the scanner, that they'll tolerate the CT, they don't tolerate the MR so much. Operationally at our site, it's harder to get the MR back fast enough to be able to process it, and a lot of the surgeons, we take some pride in the fact that we're getting the images and reading them right then, so the patients, we can answer questions for the patients. That can be a little bit tougher for MR at our site. I think that, and then the other thing that still drives me nuts is people not being clear about MR compatibility with endografts. And I'm getting questions now, tell me if I offend anybody with this one. Got a question from an orthopedist about the MRI compatibility of a Dacron graft. I went, okay.
Yeah.
You know, the orthopedists in my class were the smartest in the class. I don't know what happened after that. So there's some confusion about MR too. So I guess ideally the axial imaging is the principle. In my circumstance, most of us lean towards CT. What do you do? You like MR?
So I think it's a great question, Bill, because there are actually several publications. You almost can't justify doing CTA from the top of your head to the tip of your tongue. You just can't do it. The radiation and the contrast dose is too high. However, there are actually several publications doing global vascular imaging using MR. Now there's several, no radiation, you know, maybe some gadolinium, and so you probably can do it. Now we're very fortunate in the quality and the speed at which we get basically our MRs back, but that's not kind of taken off. Maybe it's something that we should be looking at and thinking about this. I think there's going to have to be some important breaks on the, generally imaging drives diagnosis and drives therapy, and it's the therapy part that makes us a little nervous about how many interventions can be spawned off the back of this.
And think about how much that's going to change when we get to truly population health. I think we're moving that direction, and talk about these alternative payment models that are going through and the changes. How much will that change? How, you know, if you really want to be a business person in this, and you're just trying to collect the revenue in and not pay it out, then you would probably just stop treating people after they stop paying taxes, right? Because then they're not really paying in anymore, just sort of let them go. But I mean, we couldn't get that right.
Well, I mean, if you think about it, the whole Lifeline business concept is based upon vascular screening in high-risk areas, but it's because it's cheaper. But it doesn't give you anywhere near the data that you're going to get off an MR scan. And you know, as a logical concept, takes the okay. If it's just a cost factor, well, what's the yield that you're going to get from doing total body vascular imaging in a magnet? I don't know. We'll leave that one for when you come
another
back
time.
next time. You can tell us the answer. Thank you very much indeed for your
Thank you.
Good job.
Thank you.